want to welcome everybody to Fetal Boards. Dr. Kilee Lincoln presentation with her mentor, Dr. Barrow, and then we have Dr. Aufman from Pathology, who will do the second part on placental examination. Most of you were given turning key clickers, and all that we ask, certainly want you to participate, but please turn them in before you leave. You need all of them back. So here's a reminder. We'll try to remind you at the end of the presentation as well. Dr. Lincoln.
Okay, so we're going to talk about placental examination today. It's something that we don't really do a lot of, and there are a lot of indications that most people don't know about to send placentas to pathology or not to send placentas to pathology, so this is kind of just an overview of that. We're going to start off by playing a little game, and we're taking like a pre-test. That's what the clickers are for. We're going to see how many of you know when to send placentas to pathology or not. So, first question, where should the placenta be triaged? And if you just use your little clicker and pick A, B, or C, and I don't know how many we're waiting on, but it's working. I can see the number of responses up here. We have 39 right now. It's still going. Is that everybody? Okay. So, most of you got it right. So next, who performs placental triage? I think that's everybody. Good. Okay. Cord length is an indication for examination. True or false? We're missing 2 people. Now we're missing 1 person. Come on. There we go. Oh. There we go. Okay, that makes me feel a little better, like I'm going to talk about something y'all don't know. Placentas with any visible abnormality should be sent to pathology. I'm hoping most of y'all get this one right. Okay, the same 2 people? Okay, come on, 1 more. Nope, not gonna do it? Apparently not. Okay, good. All placentas from C-section should be examined. Okay. Which of the following is an indication for placental examination? This one might take y'all a little while because there's a lot of choices. Okay, most of y'all got that one right. Okay, so just a review for the medical students in the room. This is basic placental anatomy. So you have a basal plate, which is on the maternal side, and then you have the fetal side, which is called the chorionic plate. And the umbilical cord consists of 2 umbilical arteries and 1 umbilical vein attaches to the chorionic plate, which is on the fetal side. And the basal plate attaches to the endometrial layer, which is also called the decidua, which is the maternal side. And there are tons of blood vessels in between that we're not going to go over. They are important, but not for this talk. Okay, so some of the reasons that we normally send placentas is for placental abnormalities, and we kind of went over that in one of the questions. There are multiple known causes of poor obstetric outcomes that are directly related to placental abnormalities. This is a list of some common ones that are broken up into 3 different categories. So we have sentinel lesions, which is like pretty sudden. So umbilical cord occlusion, fetal hemorrhage, uteroplacental separation or abruption. Excuse me, I have the hiccups. We also have thromboinflammatory processes, which are chronic vasculitis, the inflammation that kind of comes with meconium or choreo. And then we have more chronic issues caused by decreased placental reserve. Chronic placental insufficiency, chronic vasculitis can also fall into this category also. Obstruction, fibrin deposition, lots of things that are kind of throughout the entire pregnancy, not just towards the end. So in 1997, there was a meeting to obtain a consensus about when to send placentas to pathology. This was done with the American College of American Pathologists and the American Medical Association. And basically their conclusions of this meeting just came down to all placentas should be examined grossly in the delivery room by the physician. Y'all all got that one right. Some maternal and fetal conditions indicate a need for gross and microscopic exam by a pathologist. There are consistent, recognizable placental lesions that are associated with abnormalities or poor outcomes. And the placenta can also provide important evidence in obstetrical malpractice cases. So the benefits of placental examination are clarification of what actually happened. Why did the adverse outcome become that? Was it an acute process that happened during delivery, or was it something going on throughout the whole pregnancy? You can also have improved management of their next pregnancy if it's something that, like any phospholipid or something like that, that we can maybe help treat in the next pregnancy that can have them have a better outcome. They also said that it was an understanding, so mostly education, an understanding of what exactly happened and how it can contribute to long-term development in the babies, especially in cerebral palsy. It also lets you know that, hey, maybe something's up and you can do early interventions or to help improve those outcomes for those kids. And then, again, the medical legal issue where you can have some amount of factual evidence instead of just everybody pointing blame at everybody else. So some of the indications, they're broken up into different types. These are the maternal indications, and this is what we normally go through more as OBGYNs. So anybody who has a systemic disorder, so diabetes, hypertension, collagen diseases, anemia of less than 9. We have a lot of patients running around that are actually pretty anemic. Premature delivery, and they broke it up into different subsets, but pretty much if it's not term, you need to send it. Or if it's post dates, which is greater than 42 weeks, you also should send it. If they have a peripartum fever infection like choreo during delivery, you also send it. Unexplained third trimester bleeding, this is actually one of them that I didn't realize before I made this. Or excessive bleeding during delivery, which is greater than 500 milliliters. So postpartum hemorrhage, you should send the placenta. If they have any kind of infectious diseases, HIV, syphilis, herpes, toxos, that's supposed to be CMV, a typo, my bad, or rubella. If they have amniotic fluid problems, oligo or poly, or if they have recurrent pregnancy complications. We have a lot of patients who have IUGR babies over and over again, or lots of SABs or preterm births. All of those placentas should be examined because there's something going on there. We just don't necessarily know what it is. Placental injury or trauma or abruption. So all of the abrupted placentas, I think we're pretty good about sending the abrupted ones because it's kind of an acute process that we want to take care of. Thick or viscous meconium. So they didn't really give a definition of what thick and viscous means. We've all seen lots of different types of meconium. Some are grosser than others. Just gross meconium. If it's meconium that's only been there for a little while and it's pretty clear and you can kind of see through it, and pediatrics didn't have too much of trouble with the baby, then probably don't need to send it. But if it's pretty thick and gross, send it. Prolonged rupture of membrane. So all our PPROM patients, their placentas should be sent. Most of the time we send them for other indications because we usually deliver them for choreo or some other kind of abnormality, but even the ones that make it to 34 weeks and just get delivered need to be sent also. And then the other one that I didn't realize was substance abuse. We have a lot of patients that abuse all kinds of different stuff. So we should be sending those also. Now, we can't send everybody because this is a pretty extensive list of, most of our patients fit into one of these categories. So you kind of have to use some amount of judgment or we'll be overwhelming pathology with placentas. So this is another category. It's fetal and neonatal indications. These may not be known to us. So we don't always know that the baby has any issues. If they leave the delivery room and they look fine, we don't hear much from them unless we call up there and ask. There are a lot of different reasons that the placenta can be sent later, and we'll go over how long we keep them in a minute. So to help with pediatrics indications. So anybody that's admitted to a NICU, level 1 nursery, I don't think we really have levels here. We just do NICU or nursery. So if they go to the NICU, they probably should have it sent. Any stillbirths should have it sent. And then when we get cord blood back, if it's less than 7 or they have bad Apgars less than or equal to 6 at 5 minutes, or if somebody had to help them breathe for more than 10 minutes, or if they're pretty anemic when they come out, their placenta should be sent. High drops, I think most of us would probably send it for high drops, and that's one we would know about because the baby would be born with high drops. Low or high birth weight, less than 10% or greater than 95th percentile. They have asymmetric growth, that kind of falls under the IEGR one for the maternal. Seizures, that's one we don't really know about all the time, is if they go to the NICU and they start having seizures. It may be helpful to send the placenta to see if there was something that happened before delivery that may have caused it. Infection or sepsis, congenital abnormalities, discordant twin growth, we usually know about those. Multiple gestations, we usually send all of the multiple gestation placentas. We're pretty good about that. And then one I didn't know was vanishing twin. If they have a twin that got kind of an IUFD, we get them every once in a while in the second trimester, then we should send their placenta so we can see what happened with that. So then there is a third category, which is placental indications. That's kind of when you look at the placenta in the delivery room, if it looks funny, hence the question earlier. So if it has a infarct or mass, I typed in mass in placenta and that's the weird looking picture. I think most people would send that if that came out of somebody. I would. If they have a retroplacental hematoma or just it looks funny or it smells funny, something's not right, send it. Smaller, large size, sometimes we'll get, especially like the syphilis placentas will come out and they'll be huge. We should send those also. If they have an abnormal shape or an umbilical cord lesion, so true knot should go. We usually just look at it and say, oh, that's cool, and then we throw it away. But we should send those. Torsion, we actually had a patient the other day that had really, really tightly wound cord, and we should have sent that. Or absence of Wharton's jelly. And then here's where the cord length question comes in. If it's less than 32 centimeters or greater than 100 centimeters, which most of us don't measure, but we'll go over that we should do that in a second. Or if they have a marginal or just wrong cord insertion. So where should the placenta go after delivery? So if you look at it during the delivery and the indication for examination that fell into any one of those is present at delivery and you know it, you just tell them to send it, and the nurses usually take care of it, and they'll get it where it needs to go. If there's not an indication present at delivery and everything was perfectly normal, we refrigerate them unfixed without formalin. We usually put them in a garbage bag. It mentioned in this that you want to put it in something that won't mess up the shape of the placenta because it may be there for 3 to 7 days. So you put it in something with soft sides. Because like I mentioned before, the NICU may have a reason and they'll call down and say, hey, the baby's not doing so well, can we send the placenta? What information should you send with the placenta? We always have to fill out the surgical pathology form in Epic, and most of us just write placenta. So you want to kind of include their OB history, their estimated gestational age, or their gestational age at delivery, how they were delivered, their birth weight, their sex, APGARs, any pregnancy or labor complications. So basically why you're sending it. And then the total length of the umbilical cord. We're actually supposed to be measuring this in the delivery room, which we do not do. So what does pathology do with this specimen? This is just very quick. Dr. Aufman's going to go through this in much more detail than I know, and he actually knows what they do. So the examination begins with a gross exam. They look at the umbilical cord, the membranes, both sides, and the tissue in between, and see if it's normal. If there are any abnormal findings, they do these other exams. So they'll look at the umbilical cord in histologic sections. They do fetal and placental ends, so they don't do the whole cord, they just do parts of it. And then they'll do something called a membrane roll, which I thought was cool. I'd never heard of that. They like roll up all of the membranes into this thing and cut it in pieces. And then the placental disc will also be divided and looked at. And they look at sections from the center, and they look at sections from the edges to see if there were any problems or if they find a lesion. So there are some newer studies than the 1997 one that I mentioned that are looking at compliance with this policy. They look at, this one in particular was looking at how many placentas with an indication were actually sent to pathology. It was done by Curtin et al., and it was published in ACOG in January 2007. It's a retrospective chart review, and they looked at any live-born infants greater than 20 weeks of age at a hospital in New York. The hospital had no policy about whether to send placentas or not, so it was up to the individual who was delivering. They had approximately 1,500 deliveries, and they wanted to calculate the odds ratio of the chances that it was sent based on these separate criteria. So if you had an MFM as your OB, if you had a C-section, if you were young maternal age, if you were broken for more than 24 hours, if you were preterm 35 to 36 weeks, and all deliveries less than 37 weeks, so anywhere between 20 weeks and 37 weeks. So they had, 3,160 deliveries. 37.5% of the study population actually met the guidelines, but only 18% of those were actually sent to pathology. They were more likely to be examined if they were more preterm, or if they had a really low birth weight, multiple gestations. I mentioned most of us are okay, or send all of those. And they actually were more likely to be sent if they were a C-section. So their conclusion of this study is that the decision to submit was based mostly on gestational age and mode of delivery, and then whether the infant was admitted to the NICU or not. They also were more likely to be sent if they had a maternal fever or gross placental abnormalities. They also noted that most of the pathology request forms had none of that information that I was talking about. They just mostly said placenta C-section or placenta choreo. This is another study that is looking more at provider knowledge than a chart review. They did an anonymous survey at a national OBGYN conference, and they wanted to find if there was a reason behind the lack of examination of placentas, where people just didn't know, or they thought it was stupid and they didn't want to participate. So the survey asked a bunch of demographic questions, such as your level of training, number of years in practice, the nature of the program, where they were located, and if they had an obstetric pathologist available at their hospital. There were some more questions that gauged the awareness of the guidelines, what indications they sent placentas for, and how they used the path reports, and if they thought the path reports were useful. So they had 111 completed surveys. 50% of people said that they routinely send placenta specimens, but only 36% of them actually knew the guidelines that they were supposed to be sending them by. The subspecialists, such as MFM, were more likely to know the guidelines. And actually, they mentioned that the subspecialists like GYN and REI were actually more likely to know the guidelines, but they declined that they sent them, so they're probably in the 50% that don't. Their most common reasons for sending were infection, prematurity, and explanation of an adverse outcome. It was also noted that they were more likely to be sent if the OBGYN had been practicing for more than 15 years, or if they were an MFM, which kind of goes with knew the guidelines, so they sent it. So basically, the conclusions of all of these studies, and kind of a quick survey of our residents while I was talking about this for a couple weeks, is physicians don't properly utilize pathology exams of placentas. We can make many, many improvements in our institution, and we need to have a balance because, like I said, all of our patients kind of fit into one of those categories. We'll be sending every single placenta because we have a very high-risk population. So we need a balance between when we send them and then not sending any at all. So that, very briefly, this is kind of the beginning of the research project that we're doing for the third year, for my third year, and Dr. Barra is helping me with. This is kind of why I spent all this time discussing placentas. So what we're going to do is we're going to make a policy for the nurses to actually ask the residents when they want to send it. Because right now they just say, oh, do you want to send it? We're going to try to get it, do you want to send it because she has this, this, and this? We're also going to put a laminated sign back in their side of the nurses station and a poster in the soiled utility where we keep them, just to remind people. For the residents, this is part of the resident education. So we talked about why you should send placentas. Hopefully some of you were awake and listened, and we will send more. We're also going to put a thing on the Google Docs and the purple book, and I'm going to try to make some pocket cards, but honestly they're going to go in the drawer in the labor unit. I know that y'all are not going to carry them around, but they'll be there up there. We also wanted to get pediatrics involved. We want to put a poster in the OR NICU room. You know, the OR2 has the separate room, just to remind them that there are indications that we may not know about, and just help improve communication between all of us, and that way we can help improve our compliance with the policies. These are my references, and does anybody have any questions? And then Dr. Aufman's going to talk in just a second.
How long do I have?
30 minutes?
30? Okay. Thanks for inviting me, guys. That was a great job in explaining what should be sent and what shouldn't be. So this is a placenta. This title comes from a publication of how to examine placentas for pathologist assistants. So a lot of the information comes out of this article. To know me is to love me, the placenta. So she did a great job over indications for placental examination. I don't think we need to go over that. What I really want to show you guys is what grossly these things look like. So if you see them on the placenta, you can submit them. So, like she said, placentas are stored in a refrigerator for 4 degrees centigrade, whether grossed or not. Here, I'm not sure where y'all store them. We just receive them in formalin. There are institutions I've worked at, they will submit every placenta in what looks like a Kentucky Fried Chicken bucket, put it in the refrigerator, labeled, and we have to throw it away. So I'm not sure, and we hold it for 2 weeks. That way, if you guys have a patient that has developed sepsis, we can go back and take sections. So our numbers have definitely decreased in the numbers of placentas that are being submitted, and it has to be more. I was invited to a lawyer's Christmas party in 2008. It was all malpractice lawyers. And they found out, me and my partner, we were pathologists, and all their questions were over placentas. Obviously, this is their favorite thing to pick at and find out what's been done. And the thing that they hate is when a placenta was examined by a pathologist, it almost always ruined their chances for any type of argument. So this is going to save you guys from any type of litigation as if you send it to us. So we can even look at it later if it's at 4 degrees centigrade. There's not too much. It's okay to bunch it up. We can just unfold it. If it's in formalin, it gets a little difficult, but still we can look at it. So we do like it in the fresh state. It's easier to examine. It gains a little bit of weight once it's fixed in formalin, but we can adjust for it. Don't ever wipe off the amniotic surface. The amnion and the chorion are just, they're not adhesed together. It's actually 2 separate layers that are just forced together by the pressure of the amniotic fluid. So if it comes off, don't worry. Just try to grab it, keep it in. So what I tell, this is a lecture I put together for the residents in pathology, and I'm trying just to get them used to what to look for. So just concentrate on things that the pictures. So first thing we do is we check for odors, and very rarely will we find one that has odor, but if it does, that clues us in to look for bacterial infections. Shape, we want to recognize if it's an irregular shape, which can be due to fibroids. Of course, the clinical information is good to get from you guys. However, we've got Epic we can look up a lot too, so put down your first worry. That helps us. These are the normal sizes. And if I'm to say something here that's a little too fast or not too clear, just say, Jeff, back up, I don't get that, or show us another picture. So normal size, 22 centimeters, thickness 2.5, usually weighs about 470 grams. This is the 3rd trimester. Umbilical cords usually range about 55 centimeters. For membranes, we want to see if they're complete. Sufficient membrane should be to enclose the fetus. We want to know where the rupture site is. I try to instill this into the residents. You've got to know where the rupture site is so that you can take from that section all the way down to the basal plate. That way, if there is an infection, it usually starts at the rupture site. We can see some type of infection there. The color appearance, if the membranes are very cloudy or thick and you can't see through it, it should be semi-transparent. That's an indication of infection. Once again, if it's discolored, yellow, green, brown, the green will be meconium. Insertion, we want to know how it inserts. Sometimes oligohydramnios will cause, I'll show you in a minute, it will cause folding on how it inserts on the placenta membrane. And when we do remove the fetal membranes, we make a membrane roll. And what we do is we just cut a piece 10 centimeters wide from the rupture site down to the placenta disc. We roll it around a stick, slide the stick out. We place it either in Bowen solution or formalin. We can tie it up. Then you get nice cross sections of the amnion and chorion. This is a placenta. This is what I try to show the residents to figure out where the rupture site is. So you want to take from this rupture site all the way down to the placenta disc. Here's amnion, and this is called circummarginal, and it just means that there might be a little bit less fluid. Here's another example. And you want to make sure the shape of the placenta disc. We'll see why in a minute. So this is circummargination. This one is circumvallate, and this actually folds back and forth on itself and fibrose and makes a ridge. And we have to prove that histologically. And this is a sign of oligohydramnios. So the fetus may have some type of problem. So the fetal surface, this is another one that's good for us to look at here when you all see it. Should usually be normal purple-blue, translucent, but you can have nodules, plaques, amniotic bands. You may want to look for any little strips of tissue that's coming off. Fibrin, masses on it, any mass. And then also you want to look at the vessels and see if there are any thrombosed vessels. That's a good reason to send it in to us. If you see the arteries are over the veins, and it's more important if the artery has a thrombosis in it. So this should be, it's a little fuzzy, it's a very fuzzy. This is a normal gray-blue. And the vessels, just check those real quick if you can, if it's clear to y'all. Fetal surface with meconium staining has that nice green tinge to it. And then we see this microscopically. We have macrophages with the pigment in them. Here.
That tells you it's been there a while, right?
Pardon?
Macrophages tells you it's been there
Exactly.
a while.
And we can actually see sometimes we saw some meconium material just staining on top of the tissue and not absorbed by the macrophages yet. So we knew it was recent. I tell the residents, stretch it out, check out all the vessels. And this one looks, I think, pretty normal. Might be a little infarct there. And if you have a big infarct, you definitely want to send it in. This is one people love to rub at this and rub it off. This is amniotic nodosum. It's also caused by oligohydramnios. Less fluid in there. The desquamation sits on there and makes these little plaques. So that's something you may want to send in. What's something else that may look like this and it's easily rubbed off compared to these which are not so easily rubbed off? Caseus, how do you say it again? I forget. Caseus vernix. Yeah, vernix. So procedure for examination on the umbilical cord. Definitely the length and diameter. The spiraling of the umbilical cord, usually 0.1 to 0.3 coils per centimeter, or 1 coil for every 5 centimeters. So if you got more than that, send it in. Something's going on. Eccentrically placed, paracentrically, or volumentous. And we'll see example of that. True knots, loose knots, number of vessels, and then any discolorations, any hemorrhages, hematomas. And this is interesting. So the cord twisting, if it's associated, it's right hand twist, and people don't know how to tell, and this tells you how to do it. If it's left hand twist, it's associated with sometimes, in situ versus, okay? So how do you tell cord twisting? I was told so many different ways by attending when I was a resident, and then I found this, and this is so easy. So you just put the umbilical cord, doesn't matter which end is proximal facing you or distal, and then you look at the lines. If they're going this way, like if you make a V and the lines are going this way, then it's a left-handed on the side of the V. If the lines are going this way, it's a right-sided, and it will work either if it's proximal or distal. So, easiest way I found of doing that. Did I skip something? No. True knot, send that in. We can diagnose it histologically because these will be dilated, the proximal, and distal won't. Proximal to the placenta disc. False knots, we see a lot of these. We can prove that they're not. Furcated vessels, you definitely want to send this in because of risk of rupture. Same with the velamentous. Procedures for examination of the placenta disc, we want 3 dimensions, weight without the quarter membranes, evaluate the shape because we can have a subcenturiate lobe, and if you see one of those you want to send it in. Once again, because there's vessels that may be running in between the membranes and they can rupture. Check for the completeness of the cotyledons and their development, any blood clots and calcifications, retroplacental hematomas, abruptio. We get a lot of these from you guys, and it would help if you can send in the blood clot with it too. So what we see sometimes without the blood clot, we'll see depression in the cotyledons, and that we can see compression of the cotyledons in the villi. But a lot of times that blood clot will actually have on the decidual side the vessels that will prove that we had a rupture. So if you can see a big blood clot with any type of decidual on it, send it in. That helps with us. We'll get a serially section at 5 millimeters and look for any type of infarcts. And then if you guys can see there's any pale, congested, or normal areas, that helps by sending it in. So these are normal cotyledons, and they're complete. And usually we receive 2 pieces of umbilical cord. I'm not sure why that is. Accessory lobes, succenturiate. And if we section, we can get infarcts, and we'll say how much of the placenta disc is involved. And this is what it looks like microscopically. We'll have ghost chorionic villi. You guys know? You see? So we don't get this unless it's really been there a long time. I think we just had one recently where a girl traveled 2 hours after bleeding in an ambulance, and she got here, and they sent the placenta in, and all we had was the depression in the placenta, not the blood clot with any of histological portions that we needed. So send in the blood clot. It helps. Retroplacental. It will be attached. It takes usually 4 hours for it to attach to the placenta membrane. I'm sorry, to the maternal surface. If not, if it's fresh, it will just wipe off. Fetal membranes, once again, we're going to look for the color, see if it's opaque. If it's brown, it's hemosiderin, hemolysis, retromembranous hematoma on the membranes. Fetus papyraceous, if you're vanishing syndrome. So I've seen 3 of these. So they're interesting to see. Paper thin fetus in the membranes. You take sections of it, and it's all autolyzed tissue and also infarcted tissue. Vernix caseosum, amniotic bands. Keep an eye on those on the membranes. Fetal surface. Look for white hydropic plaques, squamous metaplasia, amniotic nodosome. Sometimes you'll see a yellow oval disc, and it's the yolk sac remnant. You can see white round subchorionic fibrin. That's important. If you see that grossly, send it down to us. Subchorionic cysts are also important. Umbilical cords, marginal is usually not a problem. Velamentous insertion, furcated, interpositional branching, length in between 40 and 70 centimeters. It's too short if it's less, too long if it's greater. Diameter associated with diabetes, thin growth restriction, focal constriction. You can have true knots, false knots on the umbilical cords. Once again, the colors, just keep an eye out for those. And then on the maternal surface, always flip it over, see if you guys can see anything. White chalky stripe, granny lesions or calcifications, usually due to infarction and necrosis. Decidual necrosis, retroplacental bleeds. Trying to think of anything else. Placenta shapes. Modeling of the tissue. This is important, chronic villitis. And then also cholangiomas will be a red spot on the placenta maternal side. It does stand out when you're cutting through it. If you're looking at the cotyledons, it may just be a red, granular, sort of spongy looking tissue. And that's it. And this I thought was interesting. Someone brought in from Europe hair care for rabbit placentas. So, do they? Oh, God. So, and if y'all ever want, you can come down to Pathology. We'd love to show you this stuff. We like being involved, and we appreciate.
Did you know the pharaohs went to their graves with the placentas? That was a common tradition.
I did not know. That's interesting. We'll have to. I'll put that up and put it in. What's that?
In situations of multiple pregnancy, assuming they look long enough together rather than 2 separate placentas,
Yeah.
what do you typically do with those?
So if we have one disc,
Yeah.
and then we have to find out if it's a DIMO, and we gross it. We like to have you guys put on umbilical clips and say which one is fetus A or fetus B. That helps. Then we can correlate our findings with the fetus. We'll go ahead and measure each, the dividing membrane. We'll measure each placenta disc, or the area on the disc. And then we'll do the dividing membranes. We'll take the roll, figure out if it's a di or a di-mo. Placenta, we dictate each area as a separate disc, and we take 3 sections from each area.
How extensively do you look for communication?
For twin transfusion, we always have to, when we get that, we will take I've been taught with using creamer, put it in a syringe and inject it into the artery and make sure it doesn't cross the dividing membrane. If it does, we have to take a picture. There's multiple, you can use creamer, we can use yellow ink. Creamer actually seems to work better to go through the blood vessels for some reason. So we will take a picture of it. How often? I've grossed so many. I had a job as a pathologist assistant where every 3rd day I'd gross 100 placentas. So out of all those, I've probably seen 4 or 5 twin transfusion syndromes and documented it by taking the photographs of the vessels running through. Sometimes they're real obvious, other times you got to trace it and show it to someone more experienced and make sure it's not really. Yeah, yeah, and I tried putting yellow ink and saline and stuff, and it just doesn't work as good as that half and half creamer. I don't know why. They might be more viscous. I'm not sure.
So one of our researchers does a lot with placentas, especially with preeclamptic patients, and a lot of times she says she just needs a piece. And if we're sending it down to you, if there's a piece missing.
No, what we look for in preeclampsia, usually we're looking at the decidual surface. And preeclampsia with the hypertension, you have the vascular insufficiency. So at the decidual surface, we're going to be looking for arteries that have not converted. So usually arteries will have a muscular wall around it. In a normal placenta, our trophoblasts go in there and they replace the muscular wall. So your vessel is more of the trophoblasts around it. And with preeclampsia, it's very often you can see the artery still in that area. So it shouldn't hurt.
If she's taking a piece.
She's just taking a little piece, unless it's that one piece that shows that area. But most of the time, there's so much there. So.
And I know you mentioned, in fact, as far as clinical information, it's okay because you have Epic. I would not encourage the residents to do that.
Yeah.
It's just like using the radiologist. The more information we give them, the better the information we get back.
And it's true, like if you guys are suspecting infection or, a herpes virus or something like that, that clues us in because a herpes virus is pretty hard. It's a lot of tissue to look for and it's hard to search for it. So if we know, we'll sit there for hours until we find what we're looking for. So she's definitely right. Put down what you're suspecting.
Coming back to the vascular, the connection between placentas, when you put in cream or whatever, you can see the superficial one. What about the one deeper? Do you have used some radio contrast material, take X-rays or whatever?
Everything that I've been taught, we just look for the arteries run across superior to the veins, and I guess it's the arteries that have the more influence on the fetus. So I've just been told superficially to look at it. I've never heard of anything deeper. Usually those large arteries stay on the surface. When you look at it microscopically, those large arteries branch way too many times when they get down into the lacunae or the, yeah.
I happen to work in an institution where they do the twin transfusion. They do it in utero, trying to stop that. And when they fail, they basically said, there's obviously deeper connections down below.
That'd be interesting. That would be a good research project. We can do stuff like that. We're always looking for research, and that would be a good one. We could even inject it with some type of latex and dissolve it and see.
Yeah, that sounds great.
So.
The reason you get 2 pieces of cord.
Yeah.
We get cord gases, and they just send them.
Okay. Oh, we were wondering. We're like, just real quick. I don't know. So.
Or they also throw the, we cut a real long cord with the baby and then.
Okay. And It was brought up a good point that usually we take 3 sections of umbilical cord, one next to the placenta disc, one next to the clip, and one in between. So we tried, sampling is important. And that's why we request, like, if you do have those abruptio, please try to find the clot with the tissue attached to it. That helps a lot. So, thanks.